Hi, so I'm going to be talking about bronchial asthma. So, bronchial asthma is said to be asthma itself is has puzzled and confused physician from the time of Hippocrates to present day. The word asthma comes from Greek word panting, but reference to asthma can also be found in ancient Egyptian, Hebrew, and Indian medical writings. There were clear observations of patients experiencing asthma attacks of asthma in the 2nd century, and the evidence of disordered anatomy in the lung as far back as 17th century. Asthma is a common chronic disease, commoner in males before puberty. Male preponderance changes to female preponderance during adolescence. Asthma presenting in middle age occur slightly more in females than males. How common is asthma? Please like my video, subscribe to my channel, and share with your friends. How common is asthma? Asthma is a global disease. The prevalence of asthma varies from country to country, regions, and geographical areas within a country. WHO or GINA estimate that up to 334 million people around the world are affected, and this global prevalence is expected to increase to 400 million by 2025. Suggested reasons for the increasing prevalence of bronchial asthma are: 1. Improved knowledge and diagnosis of bronchial asthma; 2. Increased rural to urban migration; 3. Increase in air pollution; 4. Increase in smoking; 5. Reduced childhood infections. Hygiene hypothesis. How common is asthma? Mean prevalence of clinical asthma in WA West Africa is 5.7%. North Africa is 2.9%. 5.4% of Nigerians are asthmatic. High prevalence of asthma in Africa is in South Africa. Prevalence rate is 8.1%. What is asthma? The global initiative for asthma in 2017, after various modifications, currently define asthma as follows. Asthma is a heterogeneous disease usually characterized by chronic airway inflammation. It is defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that varies over time and in intensity, together with variable expiratory airflow limitations. What is asthma? Primary care definition: asthma is characterized by the periodic occurrence of one or more of the following symptoms established by a patient's medical history: wheezing, dyspnea or coughing, chest tightness combined with one or more of the following objective criteria: reversible airway obstruction or clinical peak flow variability of more than 20%. Asthma mortality. It is estimated that about one of 250 deaths globally is due to asthma. Mortality in developing countries is higher. Causes: sub-sensitivity to asthma, delay in seeking medical care, inadequate access to health care, increased incidence of viral infection, overuse of beta agonist medication, poor management of acute severe asthma, increase in air pollution. What causes asthma? Predisposing factor. It could be allergy, tendency to produce abnormally high level of immunoglobulin E in response to exposure to substance in the environment. Number 2 is hereditary, a strong family history. Any potential risk factor must eventually interact with an underlying genetically determined pathway to result in manifestation of disease. A number of different exposure interact with various genetic background in a range of racial or ethnic groups will eventually result in change in the incidence of asthma as a result of change in pathways involving atopy, airway inflammation, airway hyperresponsiveness, or other still unknown factors. In a large proportion of patients, asthma starts in the first year of life. New onset asthma also occurs during puberty and later in adulthood. But many cases of asthma in adulthood represent the reappearance of symptoms in persons who were transiently free of problems during adolescence and young adulthood. Some substances are capable of stimulating the immune system to react by producing specific immunoglobulin E antibodies. When exposed to such an allergen, the T lymphocyte T helper 2 cytokine act on B lymphocytes and plasma cells and stimulate them to produce specific immunoglobulin E. T helper 2 lymphocytes that produce interleukin 4, 5, 9, and 13 are increased in the airway in asthma. Inflammatory cells are attached to the airway by chemokines and then bind to adhesion molecules on the vessel's endothelium. From there, they migrate into the local tissue. Sensitization occur, and on exposure to allergens again, inflammatory process is triggered by cell mediator from mast cell activated by the reaction between the allergens and immunoglobulin E. Mediators are also produced by macrophages, lymphocytes, and eosinophils. Inflammatory allergic response consists of constriction of smooth muscles, muscle secretion, fluid leakage, edema of the bronchial wall, mucosa becomes thickened, inflamed, and edematous. Causal factors: indoor allergens, house dust, mites, bedding, carpet and rug, molds, animal, cat, dog, rat, insect like cockroaches. Outdoor allergens like pollens, molds, workplace exposure to chemicals. Cats are the most problematic domestic pets for people with asthma. Swimming is the swimming is the exercise least likely to provoke exercise induced asthma. Contributing factors: indoor air pollution, environmental tobacco smoke, environmental tobacco smoke, cooking and or eating biomass fuel, outdoor air pollution, acute respiratory infection, particularly due to respiratory syncytial virus. Obesity is a major cause of morbidity that has been increasing in prevalence over the past few decades. This is increasing evidence relating body mass index to the prevalence and incidence of asthma in both children and adults. Studies have examined dietary intake of fruits, vegetables, cereals, and starch, various fatty acids, vitamin A, vitamin C, vitamin E, minerals like sodium, magnesium, copper, zinc, and selenium, and antioxidants for possible association with asthma. Protecting factor: living in rural area, on a farm, or in contact with livestock. Hygiene hypothesis: exposure during the first year of life to domestic pets. It may be that early exposure help in maturation of the immune system. Having older sibling or being exposed in early life to older children. Hygiene hypothesis: prolonged exclusive breastfeeding was once thought to protect allergic disease, including asthma, but this is no longer thought to be the case. Trigger factor: there are factors that are capable of triggering attack, and they include irritants, acute bacterial and viral infection, chronic infestation with helminths, irritant like smoke from wood, house aerosols, vehicle pollution, tobacco smoke, acute bacterial and viral infection in upper and lower airway in both children and adults. Chronic infestation with helminths may also confer protection, but short-lived episodes of infestation may exacerbate atopic disorder. Exercise, weather changes, gastroesophageal reflux disease, pregnancy, menstruation, stress, and emotional situation, drugs like aspirin, non-steroidal anti-inflammatory drugs, beta blockers. Types of asthma: childhood onset, adult onset, nocturnal asthma, cough variant asthma, exercise-induced asthma, brittle asthma, aspirin-sensitive asthma, occupational asthma. For the types of asthma, starting with childhood onset, most asthma starts in childhood, usually on an atopic background, tends to have significant variability and identifiable precipitants. Most asthma starts in childhood, usually on an atopic background, tends to have significant variability and identifiable precipitants. Adult onset, often a relapse of earlier asthma, but may have initial onset at any age, often more persistent with fewer obvious precipitants except infection. adult onset, often a relapse of earlier asthma, but may have initial onset at any age, often more persistent with fewer obvious precipitants except infection. Nocturnal asthma, common in all types of asthma, related to poor overall control and increased reactivity. Cough variant asthma. Cough is a common symptom and may precede airflow obstruction. Asthma should be considered as the cause of chronic unexplained cough. Exercise induced common precipitant. Exercise may be the only significant precipitant in children. Brittle asthma is divided into type 1 and type 2. Type 1 is chaotic, uncontrolled asthma with very variable peak flow. Type 2 is sudden severe deterioration from a background of good control. Aspirin sensitive asthma may be associated with later onset and nasal polyp. Occupational asthma forms a subset where there is an identifiable cause which may walk through an irritant or immunological trigger. Clinical features. The four cardinal symptoms of asthma are cough, breathlessness, chest tightness, and wheeze. These symptoms are non-specific but are episodic, worse at night and early hours of morning. Symptoms that disappear either spontaneously or after taking bronchodilator. A history of coughing spells not a, a history of coughing spells not explained by other causes. Symptoms brought on by a variety of factors such as dust, cold air, sudden changes in the weather, frying oil odor, etc. A patient with personal history of allergies like rhinitis, conjunctivitis, pharyngitis, and eczema, or family history. Then there is a table here to describe the sensitizer, enhancer, and triggers for asthma. Genetic predisposition are for some individual which can cause immunological response from T helper 2 to immunoglobulin E to immunoglobulin G. I think that's G4 and G1, right? Then depend on the sensitizer, which could be an indoor allergen or alti is that alternaria there. So the best thing to do is avoidance or a prophylactic immunization to prevent immune response. Then from immune response from the type 2 immunoglobulin E that we mentioned, there will be inflammation. Inflammation still triggers T helper 2, the mast cell, the eosinophils, which will go a reversible reaction to BHR, and this will finally cause wheezing. I will know that the symptom of asthma is wheezing, cough, and the rest. So we have the inducer, which are the allergens, chemical sensitizers, air pollutants, virus infection, which will cause inflammation. The inflammation can either go to the airway or cause airflow limitation directly. Airway, this irritants will cause airway hyperresponsiveness, which will eventually cause airflow limitation. And symptoms that will come out is cough, wheezing, chest tightness, and dyspnea. So the triggering factors here also includes the allergens, exercise, cold air, mm, the particulates. If the patient is on oxygen, saturated oxygen particulate also. So why is asthma often worse at night? Because we mentioned that nocturnal asthma is common to all type of asthma. Why is it worse at night? Cause not fully established may involve effects of increased vagal tone, decreased epinephrine, cortisol, or increased histamine at night. Exposure to allergen in the bedroom, dust, mites, delayed allergic response, chronic sinus problem, and or postnasal drip, then gastroesophageal reflux disease. Why is asthma often worse at night? Airway cooling at night, that is, there will be decrease in the body temperature. There is also sleep apnea, which is brief repetitive cessation of breathing during sleep by the upper respiratory tract obstruction, increased nighttime airway hyperreactivity, decreased mucociliary activity. Airway inflammation is also caused at night. Airway inflammation is also caused at night, leading to airway narrowing. Cause is not known. Diagnosing and classifying asthma. We can do the pulmonary function test, exercise test, cold air challenge, or isocapnoic hyperventilation, skin test to identify allergens, allergic provocation test, histamine or methacholine bronchial provocation test, hyperresponsiveness. So let's go to the pulmonary function test. Spirometry is useful especially in assessing reversibility. A reversibility of greater than 15%, FEV1 less than 80% predicted value, and FEV1 over FVC ratio less than 70% establishes the diagnosis. Peak expiratory flow is useful in diagnosis. A variability of greater than 20% is significant. Exercise test. An exercise test may consist of baseline peak flow measurement, then 6 minutes of vigorous supervised exercise such as running, following a peak flow measurement for 30 minutes afterwards. 6 minutes walk on treadmill, greater than 15% decrease in the peak expiratory flow rate. There could be cold air challenge, isocapnoic hyperventilation, skin test to identify allergens, allergic provocation test, histamine or methacholine bronchial provocation test, hyperresponsiveness, chest x-ray, normal in most cases, useful in excluding chest infection and complications such as pneumothorax. Features of hyperinflation may be seen but is rare. How is asthma classified? According to the British Thoracic Society, step 1 to step 5. Step 1 includes trivial and potential asthma that can be controlled adequately by intermittent treatment taken as needed. Step 2, asthma that is adequately controlled by regular inhaled anti-inflammatory treatments, usually inhaled steroids. Step 3, asthma that is adequately controlled by regular inhaled anti-inflammatory treatments plus regular inhaled long-acting beta-2 agonist. Step 4, asthma that requires step 3 treatment together with additional therapies. Step 5, asthma that requires chronic oral steroid treatment. So, clinical classification of severity. We have the clinical features before the treatment. So, here is the step 1, intermittent. For the symptom is usually less than 1 times in a week. Is usually asymptomatic, and normal peak expiratory flow between attack. Why for their nighttime symptom, step 1 just have intermittent, right? For their nighttime symptom is less than 2 in a month, and also their peak expiratory flow rate is greater than 80% predicted. Variability is usually less than 20%. Step 2 is mild persistent. Mild persistent symptoms is greater than 1 in a week, but less than 1 in 1 day. Less than 1 in 1 day. While the nighttime symptom is greater than 2 times a month, and the peak expiratory flow rate is greater than or equal to 80% predicted. Variability is between 20 to 30%. That's for mild persistent. Moderate persistent, the symptoms is daily, and they use beta agonist daily. Attacks affect activity. The nighttime symptom is greater than 1 in times in a week, and the peak expiratory flow rate is greater than 60% to less than 80% predicted, with variability greater than 30% for the peak expiratory flow rate. Step 4 is severe persistence. The symptom is continuous limited physical activity. Nighttime symptom is frequent. Peak expiratory flow rate is less than 60% predicted. Variability greater than 30%. Now, genetic factors, environmental factors contribute to cause liability to bronchial hyperactivity, which will lead to bronchial inflammation, and there can be triggers that can also cause bronchial inflammation. These triggers include infection, allergens, exercise, irritants, smoking, emotions. And the bronchial inflammation go ahead to cause bronchoconstriction, edema, epithelial damage, recruitment of inflammatory cells, mediator release, mucus production. All this will lead to airway obstruction, and the symptom for airway obstruction includes cough, wheezing, breathlessness, and chest tightness. This is the mechanism of asthma. So to just go over it again, the mechanism of asthma is both the genetic factor is a contributory and the environmental factor, and this will cause liability to bronchial hyperreactivity, which will cause bronchial inflammation and further go ahead to cause symptoms like bronchoconstriction, edema, epithelial damage, recruitment of the inflammatory cells, mediator release, mucus production. due to triggering factors of infection, allergens, exercise, irritants, smoking, emotion, and this will eventually lead to airway obstruction, and the symptoms is now coughing, wheezing, breathlessness, and chest tightness. Modern view of asthma. Allergen can either be macrophage or dendritic cell or mast cell. Then T-helper-2 cell can also go ahead, or eosinophil, neutrophil. Mucus plug. Increase this is just a modern view of asthma. How the allergens will cause triggering and release of these inflammatory cells, the mast cell, the macrophages, and the rest, and how they will react to go and cause bronchoconstriction, hypertrophy, or hyperplasia. Asthma inflammation cells and mediator. The inflammatory cells are the mast cell, eosinophil, T-helper-2 cells, basophil, neutrophil, platelets. Structural cells are the epithelial cell, smooth muscle cell, endothelial cells, fibroblasts, and nerves. The mediator includes the histamine, leukotriene, prostanoids, PAF, kinin, adenosine, endothelin, nitric oxide, cytokine, chemokine, growth factors. The effect includes the bronchospasm, the plasma exudation, mucus secretion, AROA, structural changes. Inflammatory cell, hyperplasia of the mucus gland, desquamation of epithelium, mucus plug, basement membrane thickening, neutrophil and eosinophil infiltration, smooth muscle hypertrophy and contraction, edema. All these are the inflammatory process. Asthma and inflammatory disease. This is how it will look. The clinical exacerbation, mild attack, acute severe attack are often not as much. So these are the levels of asthma control. The characteristics, the control, the partly controlled, and the uncontrolled. The daytime symptoms for control are usually none. It could be less than 2 per week. Limitation of activity, none. Nocturnal symptoms, none, or awakening. And need for rescue or reliever treatment, none. 2 or less per week. Lung function, like peak expiratory flow rate or full expiratory volume, is normal. Exacerbation, there is no exacerbation. But for the partly control, any present in any week, even if it's present in any week, the daytime symptom is more than twice per week. Nighttime limitation of activity, there may be any limitation of activity, there may be any nocturnal symptom or awakening, there may be more than twice need for rescue or reliever treatment, they may need more than twice per week. The lung function test, both the peak expiratory flow rate for this partly control is less than 80% predicted or personal best if known on any day. Exacerbation is 1 or more per year. Uncontrolled, 3 or more features of partly controlled asthma present in any week. Uncontrolled, 3 or more features of partly controlled asthma present in any week. 1 or more per year. Exacerbation could be 1 or more per year. It could be 1 in any week for uncontrolled. So there can be daytime symptom, there's limitation of activity, a lot. Nocturnal symptom is there, and so on. Treatment. The objective for treating is to make sure that there is no chronic symptom, no asthma attack, no emergency visits, and there is minimal need for quick relief as needed. Beta 2 agonists. Treatment objective is to maintain normal physical activity, including exercise, maintain lung function as close to normal as possible, minimal or no adverse effects from medicine. The goals of asthma treatment: prevent chronic and troublesome symptoms, maintain normal pulmonary function, maintain normal activity level. Goals of asthma treatment: prevent recurrent exacerbation of asthma, provide optimal pharmacotherapy with minimal or no adverse effects, meet patients and families' expectations. The definition of a well-controlled asthma: asthma symptom twice a week or less. Rescue bronchodilator use twice a week or less. No nighttime or early morning awakening. Then also no limitation on exercise, work or school. Well-controlled asthma by patient and physician assessment. Normal or personal best for peak expiratory flow rate or FEV1. The treatment strategy: first is to identify and avoid triggers that makes asthma worse. Achieve control by selecting appropriate medication. Treat asthma attacks promptly and effectively. Educate patients to manage their condition. Monitor and modify asthma care to maintain effective long-term control. Simplified guideline of pharmacotherapy of asthma. Step ladder management. Step 1 to step 4. Step 1: short-acting beta agonist as needed, indicated for all patients. Step 2: low-dose ICS, inhaled corticosteroid, leukotriene modifier, theophylline, cromolyn, or nedocromil. Step 3: low dose or medium dose inhaled corticosteroid plus inhaled LABA or medium dose inhaled corticosteroid. Low dose or medium dose inhaled corticosteroid plus either leukotriene modifier or theophylline. Step 4: high dose inhaled corticosteroid and LABA, which is long-acting beta agonist plus systemic or corticosteroid if needed. Consider monoclonal anti-IgE. Levels of asthma control, as we discussed earlier. The pharmacological treatment: there are 8 types of drugs. One is the beta 2 agonist, which is short-acting, the corticosteroid, the chromogens, the beta 2 agonist long-acting, the theophylline, the anticholinergic drugs, the leukotriene receptor antagonist, and other drugs like anti-immunoglobulin E, antibodies to tumor necrosis factor alpha. Pharmacological therapy: we have the relievers and the controllers. Relievers is the inhaled fast-acting beta 2 agonist, inhaled anticholinergic, systemic glucocorticosteroid, theophylline, short-acting oral beta 2 agonist. The controller: we have inhaled corticosteroid, inhaled long-acting beta 2 agonist, inhaled hormones, oral anti-leukotriene, oral theophylline, oral corticosteroid, systemic glucocorticosteroid, anti-immunoglobulin E, omalizumab, anti-tumor necrosis factor alpha, etanercept, interferon alpha, anti-interleukin 13. Non-pharmacological treatment: homeopathy, yoga, hypnosis, acupuncture, chiropractic, bronchial thermoplasty. Growing out of asthma, over half of children whose wheezing is infrequent will be free of symptoms by the time they are 21 years old, but of those with frequent troublesome wheezing, only 20% will be symptom free at 21, although 20% will be substantially better. In 15% of patients, asthma becomes troublesome in early adult years than it was in childhood. Asthma is less likely to go into remission in patients with a strong family history of atopy or a personal history of other atopic conditions. Low respiratory function, onset after the age of 29, and frequent attacks. Acute severe asthma. Acute severe asthma is an asthmatic exacerbation that is severe enough to persist despite the patient's optimum use of his or her conventional medication and necessitates treatment in an emergency room. Features: inability to complete a sentence in one breath, respiratory rate greater than 25 cycles per minute, tachycardia greater than 110 per minute, peak expiratory flow less than 50% predicted normal or best. Features of life-threatening attacks are a silent chest, cyanosis, feeble respiratory effort, exhaustion, confusion, coma, bradycardia, hypotension, peak respiratory flow less than 30% predicted or best. Treatment: the first line management is summarized in acronym of SOS. Short: S is salbutamol, the bronchodilator, nebulized bronchodilator. Dose is 2.5 to 5 milligram. Repeats every 20 to 30 minutes. Oxygen: 40 to 60% continuous via nasal cannula or face mask. Steroid: oral prednisolone 40 to 60 milligram. IV hydrocortisone 200 milligram 4 to 6 hourly may also be given. If patient does not respond, second line management: aminophylline 5 to 7.5 milligram per kg as a start dose, given slowly over 20 to 30 minutes. Then steroids. This last S is steroid: oral prednisolone 40 to 60 milligram, IV hydrocortisone 200 milligram 4 to 6 hourly may also be given. If patient does not respond, second line management: IV aminophylline 5 to 7.5 milligram per kg as a start dose, given slowly over 20 to 30 minutes. Then 0.5 milligram per kg as an infusion. Nebulized ipratropium bromide 0.5 milligram can be added. IV magnesium sulfate 1.2 to 2 gram over 20 minutes. Monitor the patient with peak expiratory flow rate. Measure oxygen saturation with pulse oximeter. Arterial blood gases. So we've come to the end of the bronchial asthma lecture. Please like my video, subscribe to my channel, share with your friends, and see you in the next video. We are going to be discussing the question. Please don't miss the next videos. Thank you very much.